Thank you. So, in your experience, what are the most common misconceptions about heart disease and diet that you encounter?
There's no relation.
Do you find that misconception to be prevalent in the medical profession itself?
Yeah, many of my colleagues, it doesn't matter what you eat. I mean, you have people on a heart transplant the other days. Oh, you get your out, you can eat whatever you want. I mean, it's the most ridiculous thing I've heard. Because see, the thing is this. And when I was in medical school, people get bypassed. Oh, the heart's a fix. What's happening is that when someone has an acute cardiac event, and let's say you halt that event, because I mean, stents and bypass have their place. I'm not saying they're not effective. They have their place in selected individuals. I've seen a person who would be dead if they didn't get a stent at the time they got it. So let's say you get a stent and you have massive heart attack, you're in cardiac arrest, you get a stent, it resuscitates you, you're better. Okay, that's great. But that's when you need to put them on the detox right there, right in the hospital. Raw fruits and vegetables only, smoothie detox. That's when you need to do that. You don't give them a cheeseburger the day after they got the stent been resuscitated. And that's the disconnect that we have in medicine. Because see, the underlying problem exists. If I have someone has a cardiac arrest to get stented, get resuscitated, great. You've saved their life, but they still have an underlying disease process that hasn't been fixed. And they're predisposed to having another cardiac event at some time later in their life.
So one of our speakers yesterday, continuing on this subject, one of our speakers yesterday was saying how medical schools are getting better at educating on nutrition. However, Michael Greger had a video out in just as late as August talking about how that's not the case and how there was a bill being passed to increase the amount of nutrition education in medical schools, and the the big medical organizations lobbied against the bill. What are you finding with the state of nutrition education in medical schools?
There are 3 medical schools here in Houston. I'll have to be honest, I know very little about the curriculum. My understanding from seeing medical trainees come out, these are residents and fellows, is that, and these are ones who are within the last 3 years of medical school, is that they're totally oblivious to nutrition, as I understand. And this is in my, corner of the world. So I haven't looked at the data looking at medical schools across the United States, but from what I've seen, the trainees I've worked with or am exposed to, they have virtually no exposure to nutrition that I'm aware of from whom I've worked with.
Great, thank you. Can you discuss any recent studies that have influenced your approach to treating heart disease with diet and lifestyle changes?
Really, the ones I share with you in case, and also the case series we just showed with the integrative therapies, and this is something we're excited about. Science goes through this progression, if you will. You start off with observations in isolated patients, and you see 1, 2, or 3. You say, okay, let's look at this broad scope, and we're in this whole process. So we recently, in the last 18 to 24 months, have started applying these other regenerative therapies, particularly like ozone. We've done IV vitamin C in certain situations and so on, but ozone therapy, plaquettes, chelation of a patient, and a very difficult patient with back, coronary disease, et cetera. We've done ECP therapy for about 2.5 decades, but using these integrative therapies in conjunction. So there's a synergistic effect. So it's one thing to say, okay, I'm gonna put you on a plant-based diet, and you start exercising, et cetera, et cetera. What we've started doing in this case series I just mentioned, and it's should be okay for publication within 24 hours from now. We're actually seeing a benefit to the synergies of these therapies being applied immediately. Not only that, adding exercise, which I didn't mention in my talk, but at our center there's a sports complex which is blocks away from our center, and we have a corporate contract with them. Well, not our employees have access, but our members of our life source programs have access to it. And we have 2, soon to be 3 contract trainers who work with our clients. So you have whether it's congestive heart failure, for example, one of our clients who had cardiac arrest, and he was on the West Coast and had a cardiac arrest, and was put on life support and dialysis and told he needed a transplant, and he refused all that. They took him off that. But I don't think he really needed it, but nevertheless, he came to our center, and he's gone through all these integrative therapies. He's working out with a trainer. I mean, they're not just doing walking. I mean, he's lifting weights, and he's sweating. I mean, so he's working out with a trainer. So these synergistic effects in people with severe disease get rapid aggressive recovery, and they're in the gym. We've had, if you look at Heart and Soul of a Champion, one of our patients that he has a LVAD, I'm not an LVAD, but a life vest. I mean, a life vest on defibrillators that congestive heart failure, working on the gym with a defibrillator. So, we apply these therapies synergistically, and we're finding a major benefit to early application of these synergistic therapies, as opposed to you say, okay, somebody's in heart failure, decompensated heart failure in the hospital, they get diuretics, and you watch them for a while, fluid restricting, they come out, maybe get a little bit of physical therapy, so these things are kind of stepwise. We're doing it sort of all at once. And we're finding success because of the way we do these therapies. That's the nutritional, integrative, regenerative therapies. And we find that people get on their feet fairly quickly with this approach.
So yesterday, I had the pleasure of speaking with Dr. Kim Williams, who did a presentation, and he actually referenced one of your studies, by the way, in his presentation. And as one of our participants points out, he wasn't a big fan of chelation therapy because he said it mobilizes sequestered plaque, which are aren't currently dangerous, but then will become dangerous during chelation. What's your response to that idea?
Hasn't been borne out in the studies. In fact, there were multi-center trials done. Now you have to remember chelation therapy and ECP therapy. I'll put those two together. These are therapies that are not thought to be popular within the medical community. So, for example, if say like a device company comes out with a new device and they do a study and there's some problems with it, they'll go back and rehash the study, et cetera, until they get it right and say, okay, we found this benefit, let's release it. Chelation therapy wasn't that kind of a therapy. The chelation therapy was a therapy that the cardiology community felt the frowned upon, I should say. And so what they did was a multi-center trial to disprove the effectiveness of chelation therapy. And that multi-center trials showed people, especially those who come from heart attacks, and diabetics had even more benefit, had 27% improved outcomes. Now that's better than stenting. I mean, stenting, if you do elective stenting in patients, in the COURAGE trial showed that there was no benefit in patients with a stent. Okay. Now, if you want to talk about potential adverse effects, let's talk about it. If you have somebody with coronary disease, and I do a coronary angiogram, and I look at the angiogram, I see someone, okay, I see a 70% lesion here, 80% lesion there. And we talked about this in our discussion with Dr. Brian yesterday. But then on the angiogram, I don't see that 10% lesion. Or maybe I see the 20% lesion looks like. I'm not going to stent a 10%. In fact, you're not allowed to stent a 10% or a 50% lesion. Maybe 60% if the FFR numbers are right. But the point is, I'm going to stent the 90% lesion, 7% lesion. Well, good chance that those lesions are more stable. Because 7% lesion, for the most part, some you can have the rapidly develop a 7% lesion, but those long lesions, oftentimes they have collaterals. But those lesions that develop over a long period of time frequently are more stable than the ones that are 10%, 20%. So I go put a stent there. Well, what happens when I put a stent in that lesion? Well, I'm increasing inflammation because I'm causing lots of trauma in the artery. Well, what happens with increased inflammation? Well, a stent that's 10%, 20% is vulnerable. If I increase inflammation, that creates the potential for that lesion to rupture later on. So elective stenting, in my opinion, is more of a problem than chelation because you're having an adverse effect. Now, what we've seen in our chelation patients, again, we're going to have to, publish it, but anecdotally, we're seeing is evidence, biomarker evidence that endothelial function is improving in those patient chelation. Now, the tricky part about chelation, because you're chelating things, you have to keep up with their electrolytes, the calcium, magnesium, and the like. And so we do that very aggressively. But chelation was shown to have a beneficial effect. So it was listed as a class 2 beneficial effect for treating angina. But this was at the dismay of the cardiology community. Same thing with ECP therapy. So again, it's one thing to have a theoretical concern, and I think that's appropriate. But the facts are what they are, and our clinical experience with chelation has been one that's very good. If we were saying if Dr. Williams' concern was being realized with chelation, I think we would have seen it by now, and that therapy would have been deemed contraindicated. But the reason that therapy is being allowed because it's been shown to be beneficial, and that's in a setting where they weren't standardizing the chelation therapies. We use a 3-hour protocol. Some people use a 1-hour protocol. The amount of chelation that's used can vary. So you saw a benefit even across the board when you weren't standardized. Just think of when you start to standardize the therapy, how much better it can be.